Next speaker is Dr. Vishal AGRAWAL, a very capable vitreoretina consultant from his private practice in Jaipur, and he is going to be talking on coloboma and RD.
Thank you, madam. Thank you, Dr. Joshi, and thank you, Team AIOS, for having me here. Am I audible clearly?
Yeah,
and
yeah.
can you see my screen? Thank you.
Yes, yes.
So I'll be, discussing a couple of interesting cases in which there was a recurrence in coloboma-related RD. So these are two similar cases, short videos of both of them, and similar presentations. Both were young male and one-eyed patients. One was severely micro-ophthalmic. Both eye had undergone, both cases had undergone a vitrectomy for detachment, and patient were stable, and they underwent, SOR, silicone oil removal after 4 to 6 months, and they were, apparently having good vision after silicone oil removal. One was operated at our center, one was referred from another center. But after 3 to 4 months, both of them developed a redetachment. So this is the first case. And this was, a phaco IOL SOR was done in the second sitting, and the patient was having nystagmus. This was a microcornea eye. The eye was not micro-ophthalmic. And so we augmented some of the block. And as we entered, you can see there is some hemorrhage at the coloboma margins, and there is a bullous RD. And we did all our, effort to find out the cause of the recurrence. And because the retina was so bullous and we could not see anything anteriorly, we tried to stabilize the posterior pole with PFCL. As now you can see still the retina is bullous, and that shows us that there is some trapdoor phenomena going on because the hole is getting compressed. So we made a retinotomy to drain the fluid, subretinal fluid, so that we get some space to maneuver and look for the breaks. As you can see, the colobomas are well lasered. The periphery has been well lasered, and we started doing 360-degree indentation to check the break. And finally, here you can see, if you can see here, there is a break at the posterior margin of the laser scar, and this was the causative break. And the rest areas were well lasered, and that prompted us to think what caused that break. And then under PFCL, we thought that we saw this white sheen, and then we went on with the forceps and peeled it off, and there was a whole cortical sheet of vitreous, a very thin cortical sheet of vitreous, left behind, which probably contracted in the postoperative period and caused that break posteriorly to the laser margins. We enlarged that under the PFCL, we peeled it and removed the whole sheet over the colobomatous area till the laser margins. As you can see, it's getting peeled off very nicely now. And we augmented the laser to the retinotomy which we made, and the break which was, here's the break. So, and the patient did fine, and as it was a superior break, we used a C3F8 gas, and the patient had a good vision in the
1 minute remaining
post-operative period. This is the second case, and in this also, after an apparently normal period of oil removal and ambulatory vision, the patient again developed RD. This was referred from somewhere else. And similarly, we maneuvered with the posterior pole PFCL, and here you can see the break again at the posterior margin of the CRA by the laser margins. And again, we peeled off the vitreous sheet. In this, the whole vitreous sheet was not there. It was mainly post-equator, pre-equator, not post-equator, and we peeled it. This did not come, in one piece, and we had to remove it piecemeal with meticulous dissection, and it came in bits and pieces. But finally, we were able to remove adequate amount of vitreous and leaving the traction and making the retina mobile. And the rest maneuvers was the same. After removing the vitreous sheet, we lasered the breaks. And in this case, we used oil, and the patient is doing fine in the post-operative period with the 6x60 vision. As in both these cases, the coloboma was not involving the macula, it was sparing the macula. So the patient had good prognosis. And this was a micro-ophthalmic eye. The previous one was a microcornea, but it was not micro-ophthalmic eye. So these are the cases. So what were my thoughts, while I was compiling these cases for this presentation was that, of course, we all know that it is important and yet very difficult to remove the cortical vitreous layer, especially in coloboma associated RDs. And these layers are very thin in these RDs, and you can easily miss them. and you know everything is looking so good intraoperatively, so in a seemingly uneventful surgery, and these are causes of recurrences. But the point here is I want to know with the panel, why are these cases presenting so late after SOR? Normally, if you leave this cortical sheet in pediatric RDs, in other RDs, the recurrence is, you know, quite quick after the SOR. These are presenting after a seemingly normal period, 4 to 6 months after silicone oil removal. So that was, you know, my curiosity, which I wanted to share with you. Thank you so much.
Thank you very much, Dr. Vishal. That's a very interesting case presented, and I would request Dr. Manish to discuss this.
Yes, Vishal. So the coloboma RDs are always complex situations, especially because of the size of the eye. Sometimes the viewing is issues, and you're dealing with cases which have been operated and SOR has been done. So already there is a lot of stuff done. Now, as a rule, when there's a recurrence of detachments, PVRs after oil removals done elsewhere, at least my principle is always to put triamcinolone initially, because you have no idea what has been done in detail. If it's your own case, you have a fair idea of what you would have done and maybe put in your notes, and it would be rare that you've not noted if a whole induction of hyaloid or whatever was not done. So I think that's what you've shown is a classic situation, that there are these sheets which are very easily missed by simple naked eyes. You know, unless you kind of feel it on the cutter sometimes while moving, or if you stain it, then it's very easily visible, and then you suddenly realize that the whole thing comes off, and the retina becomes more mobile, and these are obviously, as you said, the cause for the possible hole formations also. So I think what you've shown is a very classic good situation, that one has to be always on the lookout for residual hyaloid or cortical vitreous sheets in these cases. Just like high myopes, we sometimes miss them, is what I think. But great job.
Can I make a
Sir, how aggressive we need to be in doing these cases? In some cases, we don't get PVD at all. You put a triamcinolone twice, thrice, you don't get it. And sometimes
that is a sure recipe for recurrence. That's what I'm trying to tell you, that you can get away with that for a few months, maybe a year, but they will eventually, you know, cause a traction and cause posterior breaks over the laser scars, and they will recur.
Or yeah, should we try it while removing the oil? And that time, is it possible that we might find a cleavage and then we can do a PVD at the second instance if we don't get it in the first instance? Was my question.
So, but generally, what we do in SOR, we remove the oil and we see that there is a flat retina, and we are not tempted to, you know, do aggressive maneuvers during a short procedure like silicone oil removal. So we think that's all okay. Let's close it up. So that's the point, a very important point you are making, that we should be more meticulous during silicone oil removal, especially in these cases.
One point I would like to say is that in both cases, oil was removed within 6 months of the first surgery. Generally, in coloboma cases, we would probably plan to keep oil for a much longer time to allow recurrences of detachment. If they have to happen, that would be slower. So we plan to put an oil that doesn't emulsify, like 5,000 centistokes, and plan to remove only if there is an indication to remove.
So a problem with coloboma RDs, madam, is, as we all know, that the emulsification routine oil is very early, and the secondary glaucoma part is also very much. So these cases underwent SOR because of secondary glaucoma, and the whole emulsified oil came into the AC. So I think 6 months duration, the logic of 6 months oil removal was that.
So okay,
I agree with. Yeah, I agree with Dr. Vishal that emulsification is very fast because of the irregular contour. You get emulsification very early.
Very fast.
So, and the other reason you are asking about why PVR does not develop is because these breaks are generally in the colobomatous area and they don't have RPE. So, unlike normal other patients which have pediatric RDs, the RPE release is very much less in coloboma RD. That's why you don't see so much of PVR. The cortical vitreous is what caused the redetachment.
So, but that RD could have been due to a peripheral break also. We don't know about the primary surgery.
Yeah, but I think predominantly most of them are in the colobomatous area, because I think when you start...
So that brings a very good point, Vishal, that the classic sign that I always, even to the fellows, say when in coloboma eyes, when you have done a good cleanup, the first time when you operate a colobomatous eye, not for recurrences, that you do a good cleanup and you do an air fluid exchange, and when you drain from the disc or posterior pole, if the retina flattens, you know the break is in the colobomatous area. And if it doesn't, then you should look for a break elsewhere. I think that helps a lot in making sure that you have the right break. And then that way you can also choose the tamponade well. If it's a superior break elsewhere, then you don't need to put oil actually if you've done a good cleanup. And if it's in the colobomatous area, then of course we would love to put oil because of the recurrence issues.
Exactly.
Thanks a lot.